Hello and welcome to the BSAVA Science webinar, taking a closer look at some of the papers published in the Journal of Small Animal Practice. I'm Luisa Dormer, Scientific Editor at the BSAVA, and today I'm joined by Nicola Di Girolamo, Frances and Nigel Harcourt-Brown to discuss the papers RHDV2 Epidemic in UK Pet Rabbits, Part 1, Clinical Features, Gross Postmortem and Histopathological Findings, and Part 2, PCR Results and Correlation with Vaccination Status. Nicola is an Associate Professor in the Department of Veterinary Clinical Sciences at Oklahoma State University and is the Editor-in-Chief of the Journal of Small Animal Practice. Frances is a Fellow of the Royal College of Veterinary Surgeons and was an CVS recognised and European specialist in rabbit medicine and surgery until her retirement in 2016. Nigel is a Fellow of the Royal College of Veterinary Surgeons and a de facto European diploma holder in avian medicine and surgery. In 1977, Frances and Nigel set up their own practice in Harrogate in the UK. They retired from general practice in 2016, but are still involved in veterinary education about rabbits. Welcome to all of you and thank you for joining me today.
Thank you.
So both of these papers consider RHDV2. And before we kind of discuss the research in more detail, Frances, I wondered whether you'd mind recapping the differences between RHDV1 and RHDV2 and explaining the rationale for studying RHDV2 in these papers, please.
Well, I think I'll start with the similarities between RHDV1 and RHDV2. They're both Kalichi viruses of the Lagomorph genus. They both cause an acute necrotizing hepatitis. And so death of the rabbit is from liver failure or from disseminated intravascular coagulopathy. The disease has a very high mortality rate, varies between papers and maybe it's getting higher, I don't know, but both RHDV1 and RHDV2 both have a high mortality and morbidity rate. Survival is rare. I mean, I believe it can happen. But in general, it's a horrible disease. It kills very quickly. RHDV1 was first discovered around 1984 in China and has been around since that time and spread very quickly across the world. And effective vaccines were made against it for people that are old enough that can remember Silap and Lap Inject, which were the vaccines that we had prior to the Novivac Mixo RHD that came out about 2012. In 2010, or around that time, RHDV2 emerged in France, I think. And this is an antigenically distinct virus. It's not the same virus as RHDV1. It's not a variant, as we all were led to believe at the beginning of it all. And because of that, there are several differences. One of them is that there's a natural age immunity to RHDV1. So in the wild, the young rabbits wouldn't die from the disease because they have an age immunity and they would survive, and they were more likely to survive to adulthood. RHDV2 kills all ages of rabbits, including baby rabbits, so it is far more drastic on the wild rabbit populations. The other important factor between the two diseases is that the species that can be affected, the RHDV1 is really Oryctolagus cuniculi, the European rabbit, and that's pretty much, I think, the only species that can be affected. Whereas with RHDV2, it can affect other lagomorphs like hares, some of the hare species. And then I just read a paper yesterday about an outbreak in alpine musk deer. So it maybe has the potential to cross the species barrier as well, which is a bit of a worry. And of course, we'll be coming on to the other main difference between the two is that because they're antigenically dissimilar viruses, vaccination against RHDV1 does not protect against RHDV2. So the rationale for studying RHDV2, there was no rationale. We never set out to study RHDV2. What happened was when we retired, around the time we retired, Nigel and I ran a series of quite successful CPD courses in our local village hall, and I wanted to plough the profits back into rabbit research in some way. And up to that time, before that, we'd been looking at post-mortem tissues in rabbits for many years. And so I decided the thing to do was to run an investigation into sudden and unexpected death in rabbits, because I wanted to encourage vets to do post-mortem examinations. And I wanted to find out why rabbits die under anaesthetic or owners find them dead and all this sort of thing. So this is why that study was set up. And unfortunately, it coincided with the outbreak of RHDV2 in the UK, which just overtook the whole study. And so we ended up with our funds being hoovered up quite quickly, and just the number of submissions from RHDV cases. And so this was, if we'd set out to study RHDV2, we probably would have come up with something a little bit better than this retrospective observational study of what we have found during our journey through RHDV. So, yeah. So I think that pretty much says it all about that, really. So.
Well, thank you very much. I mean, I have to say that this is, you know, these are two very important articles because I would say that right now RHDV2 is kind of an unspoken pandemic. You know, we're talking about the pandemic that affects us, but not the one that affects rabbits. So we are very worried and looking very closely to this disease also in the United States. In part one of your article, you mentioned that a non-forensic postmortem examination was performed by a veterinary practitioner 6 hours after death. Could you tell us a little bit more about this protocol and how you developed it, so we can make sure that other veterinarians around the world can use the same protocol and maybe reach the same conclusions?
Gosh, that's a scary thing if I have to advise the world how to run a protocol, but I think it started because of my, well, just I always wanted to know why my patients died when I didn't. You know, it really quite awkward when something happens that you've got no explanation for as a vet. And I started my bird work because that's been a lifetime hobby. I started that, and of course there was very little known at that time, 40, 50 years ago. And I had two friends who carried out histopathology for me, who worked at the Veterinary Investigation Service. And it was really that allowed me to work out some sort of protocol where I could relatively sensibly get a range of tissues that allowed me, in most cases, to get a diagnosis. Post-mortem examination is really good, especially if you're looking at new species, because it tells you about their anatomy. And, you know, even now, we're not taught about at universities avian anatomy. Yeah, it's fine in poultry, but it needs to be something else. So it taught me a lot about that. So when Frances first wanted to start producing a protocol for rabbits, I sort of got in my mind this range of tissues, and I didn't see why we couldn't use that for the rabbits in just the same way. And we were very fortunate at that time that Abbey Veterinary Services would look at this range of tissues for a flat fee and give us a report. So it was really quite a handy thing to do. So this protocol addresses several things. It addresses the needs of the clinician, in that it hopefully gives you a diagnosis in a troubling case. It also does the same for the needs of an owner, but importantly, it also allows the vets to respect their animal and to give the owner back a reconstructed carcass that they can take for burial. And I have to say, if I've done it, usually it's quite nice, the carcass. It's not horrible, it's not covered in blood. I make it look pretty good. And then really importantly, it addresses the needs of the histopathologist in that it will give them properly fixed fresh tissue. And hopefully the vets will provide brief clinical details and, more importantly, description of the post-mortem examination that they did. The big problem with rabbits is that they're well insulated by fur and a good layer of fat if they're captive rabbits. and they have a cecum full of very active fermenting aerobic and anaerobic bacteria. So as soon as they're dead, everything starts to move out of the gut, and autolysis is incredibly quick, very similar to sheep. And so you need to do something rapidly. You can't wait till tomorrow. You've got to do it within a few hours. And so again, for a busy clinician, you need some sort of brief protocol that allows you to get, pragmatically the most out of it in the shortest period of time. And this was again what allowed me to do this. So the tissues that we requested, usually mainly of course for this study, but just for unexpected death, you need a piece of liver. Probably doesn't need to be any more than 1 centimeter thick. If you can see lesions in the liver, then it's quite nice to get a lesion, and it's quite nice to go from normal to abnormal in your slice of liver. You certainly need a representative kidney, and I used to cut that longitudinally so that it would fix adequately. The spleen, I've always traditionally taken it, although before this study we didn't used to see very many changes in the spleen, but you take half or whole the spleen. And then the pluck, the lungs and the heart and the thymus, if it's there, all as one lump attached to the trachea. It's a very handy way of presenting that set of tissue. It allows you to fix it properly. A lot of post-mortem reports on rabbits describe atelectasis, but if you fix the lungs in expansion by dripping formal saline down inside them as well as fixing them from outside, it expands the lungs and stops this often abnormal change, iatrogenic change happening. So the pathologists like it. They also have lungs that they can look at and feel and take sections of the appropriate bit rather than you randomly guessing which bit they might want. And it also gives them a whole heart. And rabbits have a lot of cardiopathology, and a whole heart for the pathologist is useful. So that pluck is really good. Any other pathological tissue is useful. If you're going to do intestinal stuff, the intestines must be fresh, probably within an hour of death. And I used to tie off and make little sausages of intestine, isolate a section, fill it with formal saline, tie it off and immerse it in formal saline. And that would stop you getting autolyzed tissue. CNS tissue, well, if you want to do that, you really need to speak to the pathologist about that before you take it and before you deal with it. I then take all these tissues and put them into a relatively large volume of formal saline so they'd fix properly. In the good old days, that was a 500 milligram, 500 capsule amphipen pot, which would just then sit there and you could just fill it up with some formal saline, stick them in there. And after 48 hours, you can drain it all off, seal them in a plastic bag, post them to the lab in a jiffy bag so the lab don't have great loads of formal saline to get rid of. Postage is cheaper. And that never, ever seemed to cause any problems with the histopathology results. So it was a nice, easy way to send the tissues. So that's it, protocol for everyone.
Well, thank you. I'm sure that it's going to be very useful. So in addition to this, what are the most common microscopic findings of RHDV2, and are any of these microscopic findings something that our listener can use to actually suspect RHDV in rabbits? And also, if you can only choose one organ to send for postmortem for histopath, because we know that sometimes our in clinical practice we get a little bit tight on money, and we can only send one sample out. What would be the best sample that you think most representative for this disease?
Well, I think in reply to that last comment, I think I'd change my lab. I think if they're only going to do one tissue from a post-mortem, that's going to be unsatisfactory for the histopathologist as well as the clinician. And I know that in the cases where labs are subject to accountants telling them what to do, stop tapping my knee. And I just can't conceive that you go to the length of doing a post-mortem and then just sit with one tissue. I'd collect all the tissues, I'd fix the whole lot, and then maybe if I thought it was RHDV, obviously I would send a piece of liver, because every rabbit that gets RHDV, that immediately targets the liver. and the organ that you're going to see the changes in is going to be the liver, unless it's died so quickly within a couple of hours of actually getting the disease that there's not been time for light microscopy to show the liver damage. Those are that's a bit of an esoteric thing. So a piece of liver, and I would use histopathology over and above PCR, simply because in our study it proved to be that bit more reliable. So that certainly is what I would say. Gross external signs on the rabbit, it used to be that opisthotonus and a nasal discharge of blood were the classic RHD. That's why it was called rabbit hemorrhagic disease. But in our study, that wasn't a key feature. And there's a guy in Spain just published a large study as well. And that was his finding, that hemorrhage from the nose was not common, or certainly not consistent. So probably the most obvious clinical sign for us is the fact that it's a dead rabbit and there's not much on the post-mortem. And you know, there's no obvious pathology. You know, there's not a nail through its head or a ruptured stomach or whatever. So that would be a key thing. In nearly half the cases that are 78 out of 185, there's this big table 2 in the paper that is a distribution of microscopic lesions. Certainly the vets doing the post-mortem in nearly half the cases reported that they saw nothing on their post-mortem, even though the rabbit died with RHDV. Well, certainly nothing abnormal. Obviously they saw something, but it didn't look abnormal. But the key features for me is this liver involvement. And so you get an enlarged liver, it looks a bit swollen, it's often got rounded edges. Be nice to think that colour was important, but they can be dark, they can be pale, they can be mottled. I think if you have a good light and if you take a magnifying glass of some sort and enlarge the view of the liver that you can see, you may see the sort of centrilobular necrosis. You may see that the liver looks more lobulated than normal liver would. But you've got to know what a normal liver looks like in a rabbit. And a lot of people who are doing these post-mortems haven't got that much experience in practice. They should get the experience, they should do the PMs. But so I think that the liver's important. The other thing that we noticed a lot was that the spleens were enlarged. In table 2, it doesn't suggest that many were enlarged, but I think the trouble with a rabbit is that its spleen's tiny, and in relation to what you would expect from other animals. So I think if it was a bit enlarged, it would be easy to think it was normal if you weren't looking at lots of livers, lots of rabbit spleens. But the spleen is usually enlarged and usually thickened and swollen with a sort of round edge. And those are the 2 key features. The rest of the viscera can be completely misleading. I mean, you can see the lungs, especially, you can see lungs with appalling look to them in normal rabbits, or rabbits don't have RHDV. You can also see lungs with obvious looking pathology, grossly, that actually come back with normal histopath. And you can see exactly the same the other way around. You think, oh, those lungs look right. Well, the histopathologist thinks they look shocking. So I don't think I can preempt any of that. The kidneys can look dark and they might have hemorrhages, but they might look just like kidneys. So again, if there's bloody fluid in the abdomen, that's pretty well a key feature, but it's not that often that you see it. And it's unusual to see jaundice because the liver's killed off too quickly for the rabbit to develop it. And one of the pitfalls as well is you can get these rabbits with yellow fat, which is normal for them. And that can look very icteric. So I think there's a pitfall there. So I would never make a definitive diagnosis of RHDV without histopath and or a PCR. And I certainly would use a histopathology on these tissues rather than a PCR. So hopefully, I can't remember if I said it, but hopefully if you're doing a post-mortem, you can only submit one tissue. Fix the rest. You can always go back to them. You know, you can cut sections in 10 years' time, let alone tomorrow. So I would fix everything, send off the liver, and when the liver comes back very unsatisfactorily without an answer, you haven't shot your bolt. You can go and look at other tissues. I think that's enough, isn't it? Yeah.
Great, thank you very much. So I want to move on now to think about your second paper, and I initially was going to ask you to kind of outline what you did, but because I'm really enjoying these conversations about the linking it to clinical practice, I'd actually like to jump to the results, if I may. So you mentioned, Frances, in your second paper that all rabbits with a positive or inconclusive PCR test result showed viral RNA of RHDV2 serotype. All rabbits that were tested for RHDV1 showed a negative result, suggesting that RHDV2 is replacing RHDV1 in the UK. And I wondered, you already mentioned this briefly earlier, but what implication does this have for vaccination programmes for rabbits in the UK?
Right. Well, as I said at the beginning, if we would set out to study RHDV2, we would have done things differently. One of the drawbacks from the study was that a lot of the tissues were only tested for RHDV2. So we had a lot of RHDV2 results and not very many RHDV1 results. So, but I think there was 37 RHDV1 results and they were all negative. And so to me, that meant that RHDV2 is replacing RHDV1. And that is borne out by many other authors all over the world that this is the case. And the main implication for the general practitioner is the fact that the RHDV1 vaccination is ineffective against RHDV2. So in the UK, and I think in many other European countries as well, the vaccine we had was Nobivac MixO-RHD, and it doesn't protect rabbits against RHDV2. And I think things have got probably a little bit even more complicated by the introduction of the new vaccine, Nobivac MixO-RHD plus the triple vaccine, which isn't being quite as straightforward as it might be because of a phenomenon known as vector interference, where basically the virus, the myxoma virus that carries the RNA material, gets gobbled up by the immune response of the rabbit if it's been previously vaccinated against with Nobivac, the original, sorry I'm garbling here, but the original Nobivac MixO-RHD, and this as being a complicating factor. So the manufacturers of Nobivac MixO-RHD plus have said that rabbits that have been previously vaccinated with the old vaccine should have a vaccine specifically against RHDV2. And this is also what we've been saying over the last 4 or 5 years since we first really encountered RHDV2 in this country. So I think hopefully everybody knows that we have 2 vaccines over here, Eravac or Filovac. And I think apart from the young, completely naive rabbits who have never met myxomatosis or a vaccine against it, any other rabbit probably still, at least for the next 12 months or so, should be vaccinated against RHDV2 with a dead vaccine.
But also with the Nobivac Plus as well.
Oh yes, yeah, well they need vaccinating against myxomatosis, yeah.
Absolutely, thank you. So in your study, were there any rabbits that were vaccinated against RHDV2 that died from the disease?
Yes, there was 13 rabbits that died from RHDV2 that had been vaccinated, but 9 of them had been, or 10 of them had been vaccinated in the face of an outbreak. Other rabbits in the household had died, or in the establishment had already died, either died suddenly with or without the diagnosis of RHDV2, and the vaccine hadn't had time to become effective. The manufacturers of Filovac, which is the vaccine that most of the rabbits were vaccinated with, say 7 days before it's fully effective. I think perhaps it was a little bit longer. Maybe there was certainly one rabbit there that had been vaccinated 10 days previously. Well, you can see that maybe that didn't have time to actually respond properly. Of the other rabbits, one of them had come with only a verbal report that it had been vaccinated at the breeders. You know, there was no real evidence that it had been actually vaccinated. We had no batch number or date. And I think at the end of it, there was one, maybe two rabbits that were fully vaccinated that developed RHDV2 and died, which isn't that many in the number that we had in the study. And Philovi only say a 90% efficacy for their vaccine. Actually, they believe it's a lot more than that, but it is within those boundaries. And we all know there's loads of reasons why you can get vaccine failures. And underlying disease is probably the big one. But you know, vaccine storage, the way it's administered, all that sort of thing.
Yeah, absolutely, thank you.
Well, thank you. Yeah, vaccine development is definitely a very difficult issue. And back in 2012, when the first vaccine marketed for pet rabbits came out, the literature was really like just including one main study on laboratory animals, and there wasn't much on pet rabbits. So some steps for vaccine development in human medicine are needed, in which you have phase 3 trials and all those things. And in animal medicine, especially in pet rabbits medicine, this has not been done in the past. And in fact, we found a number of rabbits developing dermatological lesions that were not reported in the leaflets. This was later published in 2014. So what could clinicians do in order to assist vaccine development in pet rabbits for, these vaccine or new vaccine in the future? What would be your suggestions?
Well, first of all, I've just got one comment to make there about the term pet rabbit. We've used pet rabbits in the title of this paper, but client-owned rabbit would have been a better term than pet rabbit. Certainly one of the vaccine manufacturers has been claiming that their vaccine is for use in pet rabbits because the challenge studies were done in breeds that are kept as pets, which is a little bit different than a pet rabbit. And I know of other research studies where it's the same. So they usually use Netherland dwarfs or Dutch rabbits that are commonly kept as pets. So
those are still laboratory rabbits, aren't they?
Yeah. So that's the first thing I would say. Secondly, I think it's really difficult to set up some sort of clinical trial in client-owned rabbits. I think that would be difficult. So all I would say is that I think it's very important that when people have some vaccination problem, either a vaccine failure or a vaccine reaction, that they do get in touch with the manufacturers, report it to the VMD, fill in all the necessary forms. And if it's in the case of death, we've been round a full circle here, that a post-mortem examination is done on that rabbit to make sure that it did actually die from the disease that we're accusing the vaccine failure of being about, and not something else which it could easily have been done.
Can I interject here that with that in mind, SIVA have taken on our post-mortem protocol and produced a post-mortem sheet that they distribute themselves, and is also available on our website, so that vets can sort of all do the same post-mortem. And SIVA would be keen to talk to anybody who are about to embark on a post-mortem about fees like that. I'm sure that's dropped a minute, I suppose, but there you are.
No, that's great, thank you. And I think perhaps it would be useful for us to link to that protocol from this webinar as well, so that anybody listening that wants to get involved can follow as well. I think that would be really useful. So thank you so much to all of you for giving up your time today to discuss these papers, and thank you for listening. The full version of part 1 can be found in the July issue, and part 2 in the August issue of the Journal of Small Animal Practice. A link can be found in the comments below the recording. Join us next time when we will be taking a closer look at another paper featured in the Journal of Small Animal Practice.